move on to session 6. Session 6 is meaningful patient engagement in health literacy in a digital and social media age, learning from the COVID-19 global pandemic and national Syndemic. We are excited to have as moderator none other than Dr. Ratna Devi, Chair of the International Patients Organizations, or IAPO. We also have Dr. Ratna.
Thank you, Kara. Good morning, good afternoon, and good evening to all the delegates who have come back and joined us today for the day 2 of the workshop. As Kara introduced, my session is on meaningful patient engagement in health literacy in a digital and social media age, learning from the COVID-19 global pandemic and national Syndemic. We all know that digital has become a buzzword in the last 18 months. Almost everyone that we talk to thinks that digital is going to be the way forward and that digital is going to change the way healthcare is accessed and received as well as delivered. So today's session will look at the dynamic between the pandemic and the national social determinants of health in a digital and social media driven world. Social media was there always, but has it changed because of the pandemic? Has it changed for patient groups? Has it changed the way communications are dealt with? Has it changed how patient groups are reaching out to their constituency and their membership? That is something that we need to explore. It will also look at how expert patients can co-produce attractive and effective digital health literacy and patient education solutions fast during a pandemic. In this day is the day of paper-based, tools like posters and pamphlets and booklets over. Are we now moving to something that is only available online or maybe through an app? There are certain examples like the Denso Japan, which invented the quick response code.
Hello.
It has taken over in many Asia-Pacific healthcare settings, including the COVID-19 test, trace, and track systems. Earlier this month, we had a workshop for the Asia-Pacific region where we ran a survey with some of the patient groups, and we asked them if digital had changed the way in which they could access healthcare, especially for remote and hard-to-reach areas. Most of the people who were asked this question said that digital is here to stay. The question was, do you think digital was something that was a buzzword only during the pandemic, or is it here to stay? And over 80% said, yes, it's going to be here, maybe in a slightly changed form, but it is here to stay. We asked them whether they were happy with the way things have changed because of digital. And again, about 60% said they were happy because it had increased access to many of them. When we asked them what their major challenges and major advantages were, especially for chronic care, in terms of rare diseases or people with heart failure or cancer patients, many said that it reduced waiting time, it reduced travel time, it reduced cost because they could access their specialists sitting in the comfort of their home. But then also it raised the question of a digital divide and questions of equity and equality. As we have seen, people or children who were in rural areas could not move to the education system because they did not have a mobile phone or an internet access as schools went online due to the lockdown. A similar thing has happened for people who did not have access to these tools. On the other hand, many people also said that doctors or other healthcare professionals are not traditionally taught how to use digital tools in their academic careers. So when you do your undergrad and postgrad, you are not taught how to use an EHR system or a telemedicine platform. It is only when you come to a hospital and you are forced to do it because of a situation or the hospital has it that you actually learn on the job. So is it time now to change that and introduce these systems into curriculums so that both the populations, general populations, as well as the professionals learn how to take this forward? So this is the content that we will be talking about. And it is with great pleasure that I invite our first speaker for today, Laurie Myers, and she's the Director for Global Health Literacy and Oncology for Health Equity at MSD. And over to you, Laurie, the floor is yours.
Many thank you for the introduction, and many thank you for having me here today. So when you think about the theme of the conference with compassion, insight, and co-creation, health literacy is front and center, right? When we talk and think about health literacy, and I'll speak about the formal definition in a moment, but at its heart, it's about empowering patients and empowering the general public to make informed choices about healthcare, which is very much what Dr. Devi just was speaking about. So could you please move to the next slide? So the theme of today is involving patients to advance health literacy. Next slide, please. And today I want to introduce why health literacy matters. You may be surprised that I'm from a pharmaceutical company speaking about health literacy, so I want to explain why it matters to our company and should matter to all companies. And just to give two very practical examples of how my colleagues in Australia and Hong Kong have implemented health literacy into their work, to share some very practical lessons learned and where you can learn more. And, you know, if we have time later, obviously, for questions. So many thanks. And next slide, please. So it's an unusual title to be focused on health literacy and health equity. So I thought I would just take a moment and explain what I do. So in short, I work with colleagues around the world from our earliest clinical trials through to the packaging of medicines and many steps in between to figure out what can we do so that patients are understanding their disease, understanding their medicines, understanding if they might have potential side effects, for instance, and what to do, and how their medicines or vaccines work. I do collaborate with people internally and then externally in work groups where we bring people together to think about this. And that's where the greatest impact of health literacy is when people from different backgrounds come together, and you'll hear an example later. And then to publish the work or present it to help others learn, and also to learn from others, and then to dream, right? I believe that a world where patients are fully empowered should be what we all strive for. And I know everyone here believes that. So next slide, please. So I'm not going to read this, but I wanted to highlight two aspects of health literacy, which is often people think about, can a person, you know, understand information to make an informed health choice? But the other aspect of that is, what role do organizations have in creating information? And but when I talk about information, I'm not just talking about print or, you know, a medicine. We're thinking about, you know, digital communications and all communications. So what can we do as a company so that we simplify the information so that it's not unnecessarily complicated? So next slide, please. So when we think about health literacy, oftentimes people see the word literacy and they think about people's ability to read. But in fact, there's many components of health literacy. And again, they were also touched on in the introduction as well. So the first is oral literacy. So can you speak, and also can you listen effectively? Information literacy. So can you find, if you're newly diagnosed with something, can you find information to help you understand the decisions you need to make? Print, can you read? Can you write? And this is more traditional measures of literacy. Digital literacy, and this is of course very tied into topics related to misinformation, right? Can you navigate the information that is available digitally to find the information that is credible? And are you able to navigate to sites which are credible? And finally, can you understand and use numbers, which are such an important component of health? Next slide, please. So health literacy is really important. We talked about access. Dr. Devi spoke about access. And can you access healthcare services? Can you use those services? And, you know, we all probably have examples of friends or family who were diagnosed with a condition and who were pretty overwhelmed by how do they get to a doctor's appointment, or who do they need to see, or how do they get their medicine? So can you use the services? Do you know what to do to prevent illness, the things which are controllable, or to manage your health once you're diagnosed, to navigate systems and to act on information? And, you know, health literacy is actually a stronger prediction of your health than other demographic variables. And next slide, please. So when we think about low health literacy, we often think about the risk factors for low health literacy, which for instance include lower levels of education, or having a lower income, or speaking a different language than is used by your communicator, or other things. But every one of us can struggle with health information. So if you've had, for instance, a personal experience with cancer of a family member or a loved one, we know that when a person is diagnosed, it's very difficult to process information. So we all can struggle because of emotions, for instance. Next slide, please. And you know why we care is health literacy is a challenge no matter where you live in every country. And Dr. Christine Sorensen has helped do many health literacy surveys to document that, but it increases the risk that you get sick, and it decreases the likelihood that you do health screenings and other things. And again, if you, as a company, strive to invent new medicines, but people can't use them the right way or understand them, then the value of your innovation is lost. Next slide, please. And I will not go into details. I alluded to this earlier, but when we think about how a company, and not every company has the same engagement with patients around the world, of course, but for instance, you know, in different parts of the world, the recruitment materials to invite a patient to be in a trial, for instance, or you know, materials which a patient might get during a trial, or the patient leaflet, or you know, information about biomarkers. All of these things need to be clear and understandable. Next slide, please. So improving health literacy, if I say in a really simple way, how would you explain this to your child or to your parent? That's probably a good start, right? Health literacy isn't complicated. You practice clear communication and you use familiar concepts, words, numbers, and images that resonate with the people who need the information. And next slide, please. So I want to highlight some colleagues in Hong Kong, and they reached out to me and said there were so many challenges related to health literacy. So whether it was in patients' comfort with navigating healthcare, whether it was with providers' comfort and really understanding that sometimes how they speak, that patients weren't always understanding it. You know, maybe it was being overwhelmed, or maybe they were communicating in a way that wasn't resonating. And there was relatively low awareness of health literacy. So they interviewed a wonderful thought leader. I had the privilege to meet her at the Asia Health Literacy Conference a few years ago in Malaysia. And they put that on social media. And as I mentioned earlier, there was collaboration with many organizations of, I believe it was pharmacists, physicians, patient organizations, to come together and say, how can we really promote health literacy? So again, this is not a topic that is proprietary to a specific company. It's one that we need to be collaborating because it benefits everyone. And next slide, please. In Australia, we work with a company who helps us do, reviews of materials. And quickly, the material in the middle was the original language that was reviewed for health literacy. And what you see is the principles of health literacy embedded. So first an image, but the use of white space and formatting and simple language. And so on the next slide, please. How do you go from that? Or let me talk about lessons quickly. We're not going to get everything perfectly right. If you look at all materials from MSD, not all of them are health literate, but many more are than they were 2 years ago. And so moving in the right direction is really important. You always learn from listening to patients and caregivers, again, bringing it back to the compassion, insights, and co-creation. The more that you ask patients and listen and get their honest opinions and let them know that you value their honest opinions, even if they don't understand something to tell you, it really helps to make much better documents. Having sponsorship by people at your company is very important. Sharing best practices and also thinking about policies and how can we shape them to foster patient empowerment. And this takes a long time. I've been in this role for a decade. And we'll share these slides after, but on the next slide is just a few places. Please, next slide, please. A few places, these are all free, where if you'd like to learn more, you can learn more about health literacy. I would start with the CDC Health Literacy website. There's a lot of free trainings there. It's a really wonderful way to start. So thank you very much. On the next slide, I do have my email. I welcome any questions after the session. And again, it's an honor to be here today, and many thanks.
Thank you, Laurie. That was wonderful. And the sentence that stuck to me was, you will always learn by listening to patients and caregivers. That I think is one defining statement, and I wish more and more people, actually adhere to that principle. So we heard from what the pharma thinks about health literacy and why it is important. And I will now invite our next speaker, Prue Etcheverry, who is the Regional Director for Asia Pacific Lymphoma Coalition, to hear about why digital literacy can be actually a divide instead of enhancing access to healthcare. Over to you, Prue.
Thank you so much, Dr. Devi, and I deeply appreciate the opportunity to be here today and to be talking on this really important topic. Could I have the next slide, please? Just in absolute brief terms, because there's so much to discuss actually, but wanted to actually cover the role that I think patient organisations can play here as well as patients. Health literacy really and why it matters in simple terms, and Laurie has set that up really well. Digital healthcare and just some equity considerations and patient engagement and co-creation, how that could look. The next slide, please. So I'm with Lymphoma Coalition, which is a global network of patient groups, and we have 82 member organisations in over 50 countries. Our main work is to support and help the patient organisations in those countries by giving them data and evidence-based solutions to the advocacy they're undertaking. And we mainly do that through strong planks of information and a global patient survey. That survey has really helped inform and shape what we know about patients' experiences and understandings, and does inform the background to what I'm going to talk about. Could I have the next slide, please? So in simple terms, we've heard just before about health literacy, but just in just some very simple ways here. Obviously, a patient who understands what they're reading or being told or accessing the information enables and empowers them to self-advocate around their care. Most importantly, they understand what actions they need to take. And we've seen a lot of things play out, I think, with vaccinations and the pandemic and lack of understanding about what actions people need to take, or if they're even able to undertake those actions. But they can participate in shared decision-making and have way better control of their condition if they understand the side effects they may be having and how to manage them, or the symptoms they're having and how to manage it, what they need to do. Very likely they can be more adherent to treatment and authentically can give informed consent. Next slide, please. Just an overview, and I know everyone probably knows this, but of course the pandemic really highlighted strengths and weaknesses across all countries' healthcare systems. Even the very best of them were shown up and caught out. But we saw the need for really strong infrastructure, long-term planning. One of the most stark things I think that came forth was around equity issues. And they were always there, but they were more visible and they were exacerbated. And the worst affected were actually the least protected, and oftentimes were the least able to be adherent to health messages. And these may have been essential workers or migrant workers who were doing roles where they didn't actually have health protection, or they weren't able to self-isolate, or they were in overcrowded conditions. And health messaging became really clear, but it was quite a blunt instrument and didn't take into account all those who needed to receive that message. Impacts on whole of health became clear, and I've mentioned some of those: living conditions and accommodation, but also, of course, literacy levels and language barriers. And health literacy and participation is essential in that. Next slide, please. We saw through the pandemic that patients were actually very well positioned to respond. They had databases of their patients. They had channels to communicate with them appropriately. They had the infrastructure in place. I'm absolutely aware they were also very burdened at having to move very quickly and with little resource, and often their funding drying up as they were trying to do this. But they were able to connect and communicate really quickly. And we saw with our members through Asia, but also through the world, how very vital the role was that patient organisations played between systems, hospitals, policymakers, and the patients, and getting quick and good information out there that was really specific and relevant. They're also trusted. They were a trusted, safe, non-judgmental source of information. And they're also used to providing health literate information. Again, not perfect, but it's a work in progress with all organisations. They can move quickly. When I say they can provide specific and relevant and timely information, that comes down to if you have cancer, the subtype of cancer you have, or the subtype of the condition you have, may have different implications around vaccines. Yet the health information that is coming out is really a one-size-fits-all, and that doesn't always work when people need extremely explicit information. Patient organisations also have very specific channels they can access and move on really quickly, like closed Facebook groups and WeChat. Next slide, please. Again, we know these things, how everything moved online, and we've seen, obviously, just our lives, we're all working from home, all the many, many implications of working from home. Health services, a lot of them moved virtually, and patient organisations I've just mentioned. We've seen virtual or telehealth increasing. We're seeing vaccine passports come to the fore and accessibility of information. That's all good. Next slide, please. And there's a lot of benefits to that, and many of these have been mentioned. And there's so many people that have now been included because of this digital access in terms of rurality, geographically that's involved more people. We've seen clinical trial access in different ways than it was before. Maybe young people are more engaged. And for some people, it's a little bit less threatening. But for others, it's more so. And if I could have the next slide, please. I wanted to show this because we often talk about equity and equality, and the terms are used interchangeably. And I wanted to put the slide here, and I know everyone would have seen that picture, but there are three people on both sides of that image who are looking over a fence, presumably at a game they're watching or something they're looking at over the fence. Equality is giving everybody that same box to stand on. But you can see that the person on the far left doesn't need that box. He already could see over, he or she could already see over the fence. The middle one can now see over the fence, and giving just one box doesn't help the little person see over the fence. When you look at equity, it's about assuming who needs what supports. And in a digital setting, that might be who's even got access to phones, to internet. Do they understand? Can they use those tools? Are they supported with those tools? Do they understand the language that's being used? Do they understand the technology? There's so many considerations. Could I have the next slide, please? So definitely it's not about a negative to the importance of digital and where it fits and that we need it. It's absolutely not a negative, but it's considerations of thinking who has got the ability and the access to the devices. Do they know how to use them? I've put trust there because that's an incredibly important piece. Not everybody trusts the technology or trusts the safety of the data or trusts that situation. And the motivation, not everybody wants to engage in that way. Privacy, and I know we often think about the data safety, but consider the consultation that now might have to happen in your own home when you can't be private from your family or those that you live with, or you may have to have exposed parts of your body for a person you've never met before who's down the other end of the line. You don't know who's there. All body language and nuances are gone. And of course, health literacy plays in there. So what's the support that's put in place after the digital solution? Because I think it's still really needed. Next slide, please. So I think, like with clinical trial design or HTA systems or all the places where patients should be participating, digital patients and patient engagement and engagement of patient organizations needs to be right in there from the start, if that's possible. But understanding the implications and what would be the limitations and actually who might be excluded and what might those barriers be. So opportunities for people developing those systems to consult with patient organizations and understand what really matters to people, and trust and empathy don't go away because you're in a digital setting. It's as needed as ever, but there's opportunities here. We can do new kinds of research. We can look at and develop better experiences for people with this. We've mentioned health literacy, and I've mentioned about having other supports in place. You can't just ask someone to be online for a consultation with telehealth or do something on their phone when there's no other support around that or in place. And the capacity building, and that was mentioned, I think Dr. Devi mentioned that about we need to look at who we need to train for this. It's not just the patients or the patient organizations. Do our healthcare providers need special training in this? They haven't also experienced this before. And I don't believe the age is over for non-digital information to be gone. I think it still needs to be there in some forms, and it's another layer. And I think those layers still remain important. Next slide, please. So in summary, it's wonderful. It's an opportunity. It's here. It's not going away, and we should embrace that. But make sure patients and patient engagement is part of it, or we're going to be missing a lot of tricks, I think, on this. Take very great care not to exacerbate current inequities, because if we don't actually address those in the first place, they're not going to be fixed by just reaching more people. It's what the engagement and understanding what actions need to be taken are. And so it's ensuring training. I've mentioned about digital not being the only layer, and also take into account all the cultural aspects that sit around it. And Laurie mentioned all the aspects of health literacy. That's also the context in which somebody meets and feels safe to impart information or share information. So don't layer digital on top of something that's already poorly structured. Construct something new where patients can play. Thank you.
Thank you, Prue. You used some really powerful words, words like trust, motivation, acting as a bridge, equity versus equality. And I'm sure we'll have a good discussion when we have our panel discussion. So I will now like to invite our third speaker for this session, Kawaldip Sehmi. He is the CEO of the International Alliance of Patient Organizations. And Kawaldip, we heard from a large patient alliance as well as from the industry. And IAPO being a global alliance of patient organizations, what do you think you are hearing from your members and from the patient groups as far as digital literacy is concerned?
I think that, thank you very much, Ratna. I think the first thing we must look at is that we are living in an age of tremendous change. I have in my hand a communication device, a health device, and a device to broadcast, a device to talk, a device to communicate and connect, and practically run my life on. So therefore, I have in my hands powerful tools, but these tools are not being used to the optimal level. We know for certain things that what we are saying is that we can now personalize health literacy. You know, we can be clever and use all that within our reach and hands cleverly. We know one thing for certain, that knowledge doubles every 72 days. That's a given fact, that not everybody is literate on the latest drugs and therapies. So therefore, health literacy, we are saying, is very important, not only for the patients, as Prue and others have said, but also for health professionals and our politicians. Very important. As Dr. Tudors had said, we must bring science back into healthcare. We know the other thing that was very challenging, and I think we need to look at health device manufacturers, and other communication device people to get that inter-device interoperability going, so that if I'm wearing a digital health device that can talk to everywhere, it calculates, it works out things, it can really help us. Secondly, my members are saying that with the personalization of health communication and health literacy, increasingly, patient organizations are using their narrowcast and direct remote contact ways to talk. That's our strength. We don't have to rely on mass media and interviews to get our message across. Our social media presence really helps us. We know from a health literacy point that, firstly, use plain language, that intelligent 11-year-old is our key target all the time. That's our chief customer. We know health literacy should start early, and this is with NCD Child, where they said that many of the NCDs are diseases of the childhood manifesting in adulthood. It's very important to start early. And when you start something very early, you're then able to shape the beliefs and attitudes towards science and scientific approach of disease. In Asia Pacific, we are in a very difficult position that we are countering some layers of traditional medicine with layers of scientific medicine, and in between that of science and hocus pocus, we end up in a very bad situation. We end up with the worst of both worlds. We know traditional medicine, when well controlled and used, and the nutritional values can be beneficial as a nutritional and others. But when you mix it up and try to start curing cancer, and that literacy level goes there. You saw what happened with COVID. And in India, we had steam inhaling to remedies of Ayurveda. And even one individual also broke protocol and announced that they had found a cure for it well before even Pfizer had come up with something. Secondly, I think very important for our members are saying that we need capacity building workshops and others to bring out the social and communication skills in all of us. Improving health literacy is not everybody's job, There are people who can analyze information, but there are others who can talk about that information. With this, I always recollect Hans Rosling. If you look at his work, he was beautiful in how he could visualize health literacy, health information. So we need more visualizations of health information in there. We saw one little sketch beforehand with Prue's visualization of equity and equality. We need more of those. Infographics are really helpful. Our patients don't have time. We need to grab their attention and get to this. We need to use some of the intelligent websites and apps for instance, Facebook and others, as you see, the algorithms are working in the background. We need to be in charge of those. I think it's about time patients got in charge of these algorithms and invited algorithm writers to work with us, software engineers, because complex health systems can help us funnel people to the right information. So when I input my data, it should funnel me to the right set of data. I almost personalize my journey into this health literacy. I don't see why we can't do that. If I know, for instance, Facebook, within 5 minutes of mine going online and doing something with search words, will start giving me the right products, right areas, and right things, and even the ads. Secondly, I think, as Prue had said previously, and MSD again, Laurie Myers had really said, was that let us simplify the healthcare pathways and make them seamless to use of AI and digital solutions. And that it's very important to do that. If the physical infrastructure and interaction are not right, we can't layer something on it, it wouldn't work. It's almost like putting out two materials that can bind together seamlessly. And that's how it reflects. And then my last bit on this is that health literacy is really important now if you have to shift towards self-care. This afternoon, we will be talking about self-care. And I think health literacy is important in self-care because one, the information the patient has, what he she does with it, and how does he or she travel to this, so that we can make less use of our health systems and leave them to deal with more serious cases and more needy cases. And now for political and health equity and human rights basis, I think Laura Kickbush, who has been writing very clear that now health literacy in a digital age has become a social determinant of health. If you don't have the right device and the right broadband speed in your area, then chances are you will be seriously affected by the health equity issue. And chances are your life expectancy is also reduced. So let us look at this again. I'm so glad we are hosting our Congress in Asia Pacific, Singapore Health and its digital health and its great move towards making everything digital has really moved us forward. And lastly, I think let's be creative. Our Congress theme is about co-creation. Let's all go there. We know TikTok has done lots. I mean, so you just need that little sample. Patients, please go out there, produce some good health literacy work, produce some others, communicate with patients, use it wisely, and make sure we are assisting that. And to conclude and quickly and say that, let's look at the Syndemic. Health literacy has to contend with many things that combine together and can make our life difficult, but it can also improve them. So that's where we are coming from, that it's an open world, it's a brave new world, and we need to take this bull by the horns and move forward to the next century of digital patient. We are the digital patient now, and that's what we need. Thank you.
Thank you, Kawaldip. You raised several issues around interoperability, using plain language for patients. How do you communicate when you have traditional and modern medicine having such a great interplay, especially in the context of this region, where almost half the population has great trust in, traditional medicine? You also raised a very important question about misinformation. So while digital has enhanced health literacy and made available information, there's also this plethora of misinformation that is going through social media, and how do you combat that? Also about visualization, and I really like the picture that Prue showed, because it in that just one picture, so much is said as a story about how the differences are actually creating barriers for patients. You also talked about algorithms, and we know that, if you go to any website, say, for example, Amazon, and you buy a product, after that, you have all social media channels targeting you. So if they can do targeted advertising, using algorithms, can we use the same formula to send health literacy messages to our constituencies and patients? And last but not the least, because there is so much of distancing happening now, and a lot of chronic disease patients actually are based at home unless they have an acute emergency which needs hospitalization, how do we manage self-care and bridge self-care with long-term chronic care and acute episodes of care? So thank you so much. And now we go to our next session, which is the panel discussion and the Q&A session. And I will start with the first question, which I don't know who to target to, so anybody can take this. The question is Asia Pacific behind or ahead in digital health and literacy race? Maybe, Prue, you could answer this.
I don't know if I can claim to be an expert on where that's all at, but a general comment I'd like to make is often it's ahead. Because we see digital solutions are rolling out at a different speed, and the accessibility and use of phones and is the healthcare rollout in that way might be larger. However, those same considerations that we brought up around equity remain. And I think actually I'd like to think we're all learning from each other, and we're not so much all behind or ahead, but we can just keep adding to this like AI, and just keep getting iterations on it that bring us all forward at the same time with those learnings.
Thank you, Prue. So a follow-up to this question, and I will probably address this to Laurie. We know that industries are experts in creating patient education material, and they have big teams who have the expertise to actually work on this. During the epidemic, we found that a lot of misinformation is happening, and there were various organizations trying to combat this. Now, going by the theme of co-creation, where do you see patient organizations and industry working together going forward to combat this misinformation and get the right information out there so that people are not misled or are not confused?
I wish there was a simple answer to this question. I feel like if there were, that we'd have a higher, vaccination rate around the world in many countries. Right? I mean, it's really hard. It's a very difficult question. I was hoping you'd ask me the other one about the patient information and the leaflets. But anyway, we know that social networks are highly influential, right? And so the question is, how do we leverage the people who are the influencers? And, and again, as a pharma company, there's limits on what we can do as well. It's hard. It's so hard. I'm sorry. I'm not trying to not answer the question. It's just very, very difficult with misinformation.
I completely agree, Laurie. And I think that's a challenge that all of us have to think together, because it creates much more damage than we know. There aren't enough studies to actually, put a value to the kind of damage that misinformation is doing. And maybe there needs to be some research to find out how many people did not take the vaccines because they didn't get the right information, or how many people stopped their chemotherapy because they had information on some alternate miracle therapy, things like that, which actually, give negative outcomes. Maybe there should be more research in that, and patient organizations can definitely contribute to that. So my third question is to you, Kawaldip, and I know you love to answer this question. What is important, increasing the health literacy of politicians, policymakers, and influencers, or increasing health literacy of patients and communities?
I think this is there's a Hindi saying, which I'll translate it for you as well. Jaise Raja, Vaise Praja, meaning just as the king is, so will be his subjects. Now, if the king is absolutely a duffer, if I can say that in a way, then you'll find that the population is going to be like that. And we saw those. I mean, I don't have to name names. We are a WHO officials relationship, but we have to be very diplomatic in this. But deep down in our heart, we know what we could have said to many politicians. I think they were a hindrance. They prevented things moving forward. They actually unduly risked ourselves. I think so. It's important that both that the politicians' health literacy is just as important as the mass health literacy. I think without the two, we can't work. And I'm so interested in when the European Union has come forward with this idea of the Pandemic Preparedness Treaty, and they're talking about this as a new social contract. This is something in Asia Pacific as a new idea, but Europe, because of its history in democratization and all that, they've always worked on a social contract, that there is a relationship between the citizen and the state and citizen have to have that dialogue, and they have to have that responsibility for each other and educate each other. So I liked Prada Willis' example that we are all teachers and we are all also students. So both need to work together. I think it's very important both to go tandem. If one doesn't happen, then we will have the current situation and we'll be never getting out of this endless cycle. Thank you.
May I add one other thing too, which is another example. I was actually a co-author on a publication about the need to include health literacy in the development of, in Europe, the cancer plans, for instance, the national cancer plans. And it's a perfect example, and that was co-authored with patient organizations, with people from patient organizations as well. And so it goes to the need to systematize the approach to really empowering people and also to working in a multi-stakeholder fashion, and really the power of politicians. But what I will also say is when we're talking about these issues of health literacy, many policymakers do not necessarily always have a health background. They certainly spend a lot of time in health. And so we have seen benefits of simplifying our communications about complex health topics with policymakers, because they're not going to say that they don't understand, but clear information benefits all. So I would also challenge us to really be clear in thinking about the information that we communicate at all levels. Thank you.
Yes, and also, it's not just the politicians, but also influencers. So you hear these movie stars and other people give out information, and they have a very large follow, meaning people who follow them. And because nobody questions what they are saying, it has a very large influence on how people interpret and uptake information. And therefore, I think, and many times these people are not very well informed. They are speaking because they heard something somewhere and they just pick it up and speak without understanding what kind of influence they might have on people's thinking. So maybe these kind of influencers also need to be taught what good information, dissemination is, and how can we use that to leverage good health literacy. So my next question is to you, Laura, and when you hear people giving you feedback, especially to your literacy information, say for clinical trials, etc., is there a difference between low literate and high literate information and feedback that you receive? And if it is, how do you customize this to then, serve the populations that need that information?
So we use in the development, and let me just speak to an example because I saw it was another question. So I'll just use this as an example. The development of patient medication information for new molecules. And so it used to be that we wrote it, and then after we had submitted it, and I'll start with the US because usually our labeling is done first there, and then that's the foundation for other countries in the world. And then it was submitted, and then we tested it in parallel. And what we found, we collaborated with academic thought leaders on this and realized that we need to start engaging the patients well before that, right? So for instance, when we have our first draft label, we actually go and we do focus groups with patients across health literacy levels. So you just mentioned low and high health literacy. We have one version of the document which has what we call universal health literacy precautions, which basically means everyone benefits from clear information. And when you test it with people with low health literacy, who, by the way, if all you're doing is testing it with people who volunteer with an online survey, you're not going to get people with low health literacy because they're not comfortable in that, right? Or if patient advocates are incredibly important, but if those are the only people you ask, you will miss the input of people with low health literacy unless they also are directly engaging, because the things which are confusing are not necessarily the same things as are confusing, to people with higher health literacy, for instance. So it's really important when you do that to say, if there's something you don't understand, please tell us. We'll tell us what we're trying to say, and you help us figure out how to say it. And what we find is that people with low health literacy truly appreciate that. They feel empowered in a way they don't usually. But people with high health literacy also appreciate that, because they'll say, I may be a caretaker of my parents. I may be diagnosed and be overwhelmed. And by the way, I also might be busy, and this can help me find my information quickly. So I think there needs to be one version. And I know Prue, I believe, mentioned being really understanding who your audience is, being culturally tailored, not trying to create one document for everyone, but for the audience you intend to serve is incredibly important. But everyone benefits from clear communication. Thank you.
Thank you, Laurie. That was really insightful. My next question is to Prue, and I'm asking this because you did a very large global survey where you use data to analyze what your patients need and what are the biggest challenges as well as opportunities. And now with more and more countries becoming very stringent on privacy rules and data use rules, how much do you think privacy and data protection is a booster or a hurdle for uptake of digital health and literacy? And do you think there are challenges to that? And how can we overcome them?
I do, and I think there can be the same safeguards. I guess it's not any safer having paper records that are in an office or available to other people that could have a look at data. We've had in our country here, we've had one of our major hospitals hacked, and it took that healthcare system in that region down, and for many more weeks than they thought it was going to. So you can have that, and because they had things in different forms, it took a long time to get that going. So yes, there's always a risk around data safety, and there's always considerations. I don't get the feedback from patients that that's their very first concern. It's kind of where it needs to be protected, and please don't get me wrong about that. But what we've learned about, with the reference to the survey, is the right sorts of information at the right time. And actually, across that global patient survey of 12,000 respondents, something like about 2% said they had too much information. So people don't actually think they have. I know people feel like they're bombarding patients with information. They don't. People do want that information. They assume and trust that their data is kept safely. But I don't think it's that. I think we have to trust that, and we have to ensure that it's there. But again, that's involving patients and understanding which aspects of that they're okay about being shared and which they're not. We share our lives, to Kawaldip's point. We put our whole lives into our phone, and freely share that without much consideration. I know health data is different.
Thank you, Prue. And that leads me to the next question very beautifully, because I was just going to ask Kawaldip. He showed us a mobile phone saying, this is what controls my life now. And this is my health, meter. This tells me my doctor's appointments. This tells me when I need a prescription refill, etc. But if I had an Android phone and I changed to an Apple, then these two phones don't talk to each other. And my whole data is lost. And I don't know what to do. I have to download everything all over again. And maybe I cannot do a doctor's appointment because the doctor's hospital system doesn't talk to my phone. So you talked about interoperability and making lives easier, but here I see that it is making lives even more difficult. So Kawaldip, how do you think this can be overcome, and what should be done as patient organizations to address this problem?
I think that this is, I call it the classical Hawaii case. Yeah, we need to. This is a geopolitical issue. I think first, it is it's above us. You find that unless we sort this out, we are not going to move forward. Currently, you find you've got the state in some countries during the pandemic, and this is the funny part of it. During the pandemic, some states knew where their citizens were, what they were doing much better through some of the, what I call spyware, better than their test and track and trace systems, and that needs to change. I think we need to change. Unless the state, again, comes up with that, we need to have standards now built and standards of trust. When Dr. Tudor said we must work in global solidarity and national unity, that's what he meant also, that we should have these common standards. Interoperability needs to be then looked at that. I think code sharing and others are essential elements of this. We use multiple devices for our own safety because we know we lose these devices and then we need to move on others. And it can be tremendous upheaval. I mean, I've known people who actually depressed, and it's almost like a mental health issue when they lose a phone. This is your whole connectivity. And to some degree, I know I can now access my patient records. I can book my appointments. I can see my results. I can even track how I'm maintaining some of my vital signs. And my health professionals can record that and alert me if there's something going wrong. And therefore, I'm connected now. If I can't talk to them, then my whole life collapses around that. And I think that's what we need to now look at, that we make sure that there are the safeguards, but also easier ways. We have moved away from using retinal scans and others to try to make that transition possible. But the use of QR code and others, well, more needs to be done. I think Laurie had said it very much, that the industry is pushing hard, and what the industry is counteracting is that regulatory impasse. So the industry is now gone digital throughout, but the regulation is still analog. And I think that needs to be shifted. I think the regulators have to be educated and brought up to stage to see, because otherwise we're going to kill that golden goose of health literacy, digital health literacy, if we don't do that. Thank you.
And may I just add one thing, which is making information digital does not make it health literate. So we also need to make sure that as we make information electronic, we still are adhering to the principles of digital literacy.
The standards, I think we had the websites with standards, but we don't have anything for apps now. anybody can get up, make something tomorrow, and then it's counted as a health app, and
And
does a lot of damage.
And it's impossible to differentiate. As
Yes.
a person, sometimes misinformation can look quite authentic, and it can model legitimate information. And we looked at a bunch of queries a few years back and found that was one of the most difficult things for people with low health literacy, was to differentiate between misinformation and high quality health information. And I think apps is a perfect example of that.
And to add to that a little bit, we've had live examples in all our countries, surely, about vaccine rollouts and what's happened with that. And so certainly misinformation, but there's a piece in there about timeliness and specific and targeted information, and targeting the right audiences with the right messaging, because a lot of misinformation took hold because the legitimate, let's say, information was too slow getting out there, and it was too bound up in bureaucracy, and too trying to be perfect, when actually people needed quick, good, safe, reliable information quickly. And but in the slowness of bureaucracy in a lot of places, we've now got very entrenched misinformation issues
Thank you.
with the vaccine.
I think for Laurie, for precision medicine, I think your field, we've got drugs that are quick and responsive. They can, like with liquid biopsies, even a small little bit of the cancer tumor that comes off, you can be picked up. For that, we need quick response. And therefore, if we don't have literacy systems who are attuned with that, we lose the benefit of precision medicine. I think this is what needs to get to the politicians, that health literacy in quick time, real time, like Prue has said, is sometimes a matter of life and death, especially with lung cancers, where we need to make sure these things are. So we have tools here, but because of that slow information, we are losing that benefit of this. Precision medicine cannot work without that quick, fast, precision literacy.
But even health literacy is necessary before all those steps, to know to get screened, to navigate the system. If you're diagnosed, to even know that you need to get tested, and many other aspects. And so I think health literacy matters from the beginning, right? And, anyway.
Thank you. And just before we wrap up, the last question. We do know that health and wellness has become big and a buzzword. And there's a very thin line between health and wellness and how people access their health and wellness information, and all these Fitbits and everything else that actually measures and monitors your heart rate, your pulse rate, and your calorie burns, etc. And they interplay between long-term chronic diseases like, say, diabetes. How do you see health literacy changing, with health and wellness sort of encroaching onto the health literacy for actual chronic disease management? And anybody can answer.
I would make one comment just more in general around health and well-being, is that we are learning there are greater domains to well-being and health, or ill health, than just the part of the body that is unwell. And that if we don't address and look at all those pieces, we're missing a very great trick. And that is people's mental health, which is also sitting alongside the pandemic that we have going on, and in itself is a barrier, let alone health literacy, for people knowing how to access care or be able to take the right actions they do. So I think the taking into account the whole aspects of what needs to come into it, the wider definition of health that we need to be considering.
Thank you. Any last comments, Laurie?
I was just going to say, I remember we talked about this many years ago at a health literacy roundtable meeting, and one of the physicians said, my patients with the most financial challenges are not the ones who are wearing my Fitbits, is what he said. He said, and I can't speak to the differences today, but what I can say is I view that in the, not the luxury category, right? But you're more likely to have high health literacy. So the question, to come back to Prue's wonderful talk earlier, is will this inadvertently exacerbate inequality and foster health inequities, right? Because it's a privilege to own a wearable, and it's not necessarily inexpensive, and they do die. I can, speak from a couple of them myself. So, and by the way, Ratna, one thing you asked about was patients combating misinformation. And something I didn't say, which I should have, is if we think about our friends or family who have had vaccine hesitancy, it is the power of the conversation, right? My mom initially had some hesitation and having information in one-on-one conversations. And, we're all patients at one point, and we all have, friends or family. And so the power, I believe, of the one-on-one conversation has been quite powerful, and it's an opportunity for all of us.
Thank you, Laurie. Great takeaway message. Thanks for a wonderful session. Thank you to all the speakers, Laurie, Prue, and Kawaldip. It has been a fantastic session discussing the whole issue with you. Thank you so much. Back to you, Kara. Thank you.